Hi guys, good evening. What we are going to talk today is on radiology of spine, specifically on the MRI. We have already had some discussions on how to go about with the X-rays, and it's a part of the continued series where we are discussing on how to read important specific radiology of the different joints. Let's talk about the spine. Before we start with the radiology of the spine, I'm not going to waste time on the advantages and all that. Let's directly jump to what do we need to see when we get an MRI in front of us. So, couple of basic things that we need to know is a concept called as T2 weighted image and T1 weighted image. See, T2 weighted image. So, what happens is there's a big magnet which sends across beams, and that is taken up by different structures of our body, like the bone, the soft tissue, the nerves, and the liquid or the CSF which is there. Just a sec. I think I'll have to mute everyone. Yeah. So now, so what happens is the different areas of the spine pick up magnetic rays differently, and then they give it out, and which is caught by gantries, and then you get certain images. So two specific image that you get is T1 weighted image and T2 weighted image, around which all MRIs of all part of the bodies are discussed. So what is specific is in T2 weighted image, you will see that the water is white in color. And we know that the canal or the column which holds the CSF has got water in it, and that appears white on T2, whereas black on T1 weighted image. Yeah. The other thing that you see is the bone is basically black in T2 weighted image, whereas it is grayish in a T1 weighted image. And the third thing that you notice is fat, which is white again in both in T1 and T2. These are a couple of basic things which will get polished with time. But what you need to basically know is where water you see white in color is T2 weighted image, and where you see water which is dark in color is T1 weighted image. Okay. So the whenever you get MRI, what you see is these kind of films. So typically you have four films that you have, which are divided into sagittal images and axial image. So something that you see here is basically a sagittal image. So what you do is pick up the sagittal images and then identify which one is a T1 weighted image and T2 weighted image. So see the CSF column, what appears black is T1 and what appears white is T2. So first pick up the T2 weightage sagittal section. So what exactly is sagittal section is, I'm just going to stop sharing the screen for a bit, okay, and just have a look at what I want to show you here. So if this is your spine, yeah, if you look at the spine from the front to back and you cut the spine like this, you get something called as coronal sections. When you see the spine from the side and you cut it down like this, you get the sagittal sections. And when you see the spine from the top and you cut it like this, is where you get the axial sections. The idea of an MRI is that you get sections in different planes. So you get sagittal plane and axial plane, and the sections are cut at particular interval. So a sagittal section will be a cut taken here, and from the rightmost part it starts cutting the body into the leftmost part, and axial sections are from the topmost part of the body, the sections are cut to the bottommost part. So by seeing different sections at different places, after some time you will be able to 3D visualize exactly which part of the spine is creating a problem. Now in the MRI, what you should see is grossly the alignment of the spine. Then you start going into the individual parts of the spine, which is the bone and the nerves. Okay. So, and finally, start dissecting out each bone and see the quality of the bone. And lastly, see the discs and the joints and the pathologies bothering the nerves. So, if you follow a particular sequence, you'll be able to read a MRI well. So coming back to our MRI, the first sequence that we take in our hand is a T2 weighted sagittal sequence, which will look like this. when you take the sagittal sequence, you try identifying all these points on, try, just one second, I'm going to start sharing the screen again. Yeah. So the first thing is you pick up a T2 weighted sagittal section, and then you start identifying different parts in those sagittal section. So what you need to know is which is the rightmost part and which is the leftmost part. Okay. And then you start going from the parasagittal sections slowly towards the mid sagittal section. Okay. In the parasagittal, and then once you identify and get a basic hold on which is the right side of the body, which is the left side of the body, which is the parasagittal part, which is the mid-sagittal part, then you start looking at different things. So how do you identify a parasagittal section? Is basically a parasagittal section is a section which cuts the spine into halves, right? So from the top, you if you see, it is going to cut your spine over here. So what you see is bones, the spinal cord, or the roots. In the back you see again the spinous processes and the ligamentum flavum. So this is what you see in the mid sagittal section, whereas a parasagittal section is a section where the spine is cut from the side. Okay, so when the spine is cut from the side, you see the foramens and everything. So this is how the parasagittal section is going to look. All right. uh, the parasagittal sections, or technically the sagittal sections, are not very useful only and only in cases of scoliosis, because in scoliosis you have a crooked spine, and when you have a crooked spine, what happens is that when the cut happens in the spine, at some place you see the mid sagittal and some place you see the parasagittal. Don't really get confused about all these things. Later you'll understand what is the importance of what. So once you know what the parasagittal section is, what the mid sagittal section is, you start looking first at the mid sagittal section. Okay. In the mid sagittal section, you will get an idea about these things. So you will get an idea about the bones, the alignment of the bones, the discs which are there in between, the posterior bony structure. You can see individual spinous processes. You will be able to see the ligamentum flavum in between. You will see the spinal canal going from here inside, and you will be able to appreciate where the pathology is. So this is how your mid sagittal section is going to look. On the other hand, the parasagittal section will be able to show you the bone, the pedicle, and the facet joints, and in between two bones you will see this hole which is called as a keyhole from which the nerves go. So you take up the T2 weighted image. In the T2 weighted sagittal image, identify the right parasagittal, the left parasagittal, and the mid sagittal section. And then you start dissecting out further. In the mid sagittal section, look for the look for alignment, look for quality of bones, look for the quality of disc, look for the nerves, and see if there is any compression at any level. Also see if there is any other red flag conditions that you can identify. All right. In the parasagittal area, you look for the keyhole. So keyhole is where all the magic happens in the spine. This is where the nerve root comes out. So if you see this, that is the keyhole, and you see this black structure around the fat which is white in color is basically your nerve root that is coming out. Okay. And if you see a anatomical specimen which is cut, you will see that this is the root, and this is the disc that has bulged out, which is pressing this root area. So that's basically what the keyhole is all about. So keyhole sign is basically where you can see that all the keyholes are fine, except at one level the keyhole is blocked. So you see a small nerve which you can see at other places, and the disc material is pressing the keyhole. So here you know that the patient is having pain in the 5, 4, 3. In the 3 exiting nerve root, the patient should have pain, because that is the keyhole that is causing the problem. If you actually see the MRI, you will also see a lot more degenerative changes at other level. But here, for us, what is important is the correlation. So if the patient has got a radiculopathy in the L3 distribution, and you see that the keyhole on the right side at the L3 is again compressed, then you know that the problem is matching, and this is because of the disc. Okay. Once you have your sagittal sequence into hand, you will be able to find out what level is the problem. So for example, if I have this MRI with me and I pick up this MRI, I see that there are multiple discs which are degenerated. At one level or two level, the discs are getting bulged. So this we get information from the sagittal sequence. When we see the foramens on the respective side, we see that the foramen is all right. There are certain places where the foramen is getting compromised. So here, if you see, the nerve root is getting compressed, whereas here the nerve roots are completely free. So now what you want to do is you want to see what is happening in detail at that level, is where the axial sequence comes into picture. And there is where you have to pick up something like which looks like this. Okay, so that is the axial sequence. And in axial sequence, you again have to pick up the T2 weighted axial sequence. So pick up the sequence where the central canal is looking white in color. Once you have that, you start identifying the parts that you want to see. So now we know.
Priyank, just to stop you there, is
Yes.
that keyhole that you're talking about seen in all MRI sagittal
Yes.
sections, or
Yes.
does it depend on the way the patient was in the MRI when
No,
the
no.
MRI was
So
taken?
what happens is, except for scoliosis, which is a structural abnormality of the spine, where when the patient MRI is done, you never get a clear parasagittal or mid-sagittal section, because a area which is parasagittal at one place could be mid-sagittal at the other place. You understand how? Because the bone is crooked. So when the bone is crooked and you take a cut, at some place you'll have parasagittal and other place you'll have mid-sagittal. So except for this condition, all other conditions, the sequence is going to be fine, because as soon as a patient lies down, even if the patient has got a major list and he's crooked when he's standing because of a disc problem, when he lies down, his body straightens up. And the MRI, the body is placed in such a way that the spine is straight. So it doesn't matter what position the
And
patient is.
and we are supposed to look at keyhole screenings, in
Yes.
the sense there
Yes.
will be a left parasagittal and a right. So
Yes.
that will be at two ends of the sagittal images on the
Correct.
MRI film, right?
So, yes. So, if you take this, this is how you get a sagittal film. And sagittal film has a universal dictum, unless mentioned otherwise, it is cut from the right part of the body, going towards the center of the body, and eventually going towards the left part of the body. So, you identify three special film parts of this film. One is the right parasagittal, one is the left parasagittal, and the other part is the mid sagittal. So when you identify these 3 points, then you can start studying that film. And these things are going to be standard in all MRIs.
Perfect, perfect. Thank you.
Okay.
Yeah, please
So
please
one,
go on.
so once we have identified broadly on a mid sagittal, which gives you an image similar to an X-ray, a parasagittal, you have a brief idea that the problem is lying at the 3-4 area, 4-5 area, and 5S1 area. Whatever area is there, there you want to see in detail, and there is where you're going to get an axial film in your hand. Now, axial films are again put in a particular way. Usually, it goes from the top to the bottom. So if you have the L1 area over here, then you have the S1 area down there. And again, the cuts are made at the specific areas. So one cut goes through the middle of the body, one cut goes through the disc space and the facet joint, and one cut goes to the pedicle. So usually you have three cuts done at every level. And to make life easier, they also label it. So if you are smart, you can just read the labels and catch hold of this. For example, you see here it is mentioned L3, which means that this is an actual cut from at the level of L3 body. Okay. If you see, there's a tiny reference image over here also, where, and if you see here, this is a pilot image where there are a lot of cuts mentioned over here. So here you'll see numbers 1, 2, 3, 4, 5, 6. And here you'll see 1 out of 16, 2 out of 16, which means this image corresponds to this line 1 over here. This image corresponds to this line 2 over here. So that also gives you a basic idea. Once you have your bearings right, you then proceed to identifying what the problem is, and then you start seeing these areas. So at the problem area, you want to see the central canal and try to learn to appreciate how the central canal gets compressed. So you can have a central disc which is coming out, which is compressing the central canal. So you see the difference between this and this. Again, there's a disc which has come out, which is compressing the central canal over here. So you can again appreciate here. You have a disc which is more on the right side, so it's compressing the central canal on the right side. So this is how the central canal starts getting compressed. And here, what is getting compressed in the body is these dots here, which are the nerve roots enclosed within the dural sac. Then you start looking at the lateral recess. So lateral recess is the place from which the nerve exits at every level. So at every level, you have got this hole, right? So this hole is where the nerve is coming out. So from the central canal to the outside, there is this tunnel which is called as the lateral recess. And stenosis of this you should learn to identify. So it can happen because of a disc and a full facet. So here the left lateral recess is blocked. It can be because of a disc which has come out over here. Again, here the left lateral recess is blocked. Or it could be because of the joint extending outside and forming a synovial cyst, which is also called as a facet cyst, causing a compression on the right side. Or it could be a global compression causing compression on both sides. So here you should learn to identify the block. Suppose if you're confused, if you don't know if the block is significant or not, all you do is see the upper level. So as you see in the MRI, there are multiple different levels which are there. You see the upper levels and see the lower levels and compare. Then you will be able to appreciate that it is getting blocked at a particular area.
Priyank,
So
on these axial sections, are
yes,
we looking at these vertebrae from the top or from the bottom? In the sense, is the right of
yes.
the
So here,
patient?
this is the right side of the patient. That is the left side of the patient. So our right is patient's left and our left is patient's right. Got it?
Okay, great, great. Yes, thank you.
So that's how you see anatomically the actual cuts. So this is basically how you go about reading an MRI. Now MRI, as I told you, you just pick up the T2 weighted images, because T1 weighted images, stir images, coronal images, contrast images are basically add they add value to your MRI. They help you differentiate between different conditions. But if you are able to just read the T2 weighted images, you will be able to cover up 80 to 90% of all the conditions. All right. So don't get too confused. This is a practical bit that you pick up. And then you start seeing how every condition is going to look on an MRI, because it's very famously said that only what your mind knows is what your eyes is going to see. So you should know what is happening in the body and should correlate on an MRI. Now, the first thing that goes wrong in the spine is something to do with the disc. So you have a normal disc which starts degenerating. At some stage, it starts bulging, herniating, thinning, or a lot of degeneration with osteophyte formations. So this is the different things that you can see on an MRI. So when you actually see that on an MRI, this is how a normal MRI is going to look. Remember, again, all of these are T2 weighted images. Somewhere you will see T1 weighted images also, but T2 weighted images is where you have to identify all this. So your disc will look white in color with a black outline. And, behind your dural sac, you will see empty white spaces. This empty white spaces is basically nothing but epidural fat. Okay. Then the disc starts degenerating, becomes black in color. At certain stages, it starts bulging. Sometimes these bulging discs can start prolapsing. So the difference between a disc bulge and a disc prolapse is the bulge is where the tip is pointed and the base is wide. Whereas a prolapsed disc is where the tip is broader than the base. Okay. This is normal. This is probably going to cause a problem. Okay. And sometimes the disc completely comes out, detaches, and is separately seen, which is called as an extruded disc. Okay. The disc degenerates from a normal disc to a darkened disc to arthritic, to a collapsed disc to a completely collapsed and settled disc. So these are the different types of discs you will see on an MRI. And at any stage, one of the discs can get prolapsed. So when it gets prolapsed, what happens is that the disc comes out, right? So again, this is how a prolapsed disc is going to come in front of you. You will see a seemingly normal MRI with normal discs at other level. One disc which is bad, which has come out of its place, and you will see that there is constriction over here. If you see the actual cuts of the same patient, what you are going to see, yeah, what you're going to see is you will see that the central canal is getting obliterated on the right side. So some nerve roots over here are getting compressed. And if you are smart enough, you will see that this is 5, this is 4. So you want to notice the 4-5 axial cut. You read this L4-5 and you know this is 4-5 axial cuts. Okay. So this is how you see a prolapsed disc on a spine. So what you note on the disc is one, where how many levels of disc prolapse are there. Okay. Is the disc at the same level or is it migrating down than that level? You see, if suppose you are very strongly feeling that there's a disc problem, but the central canal is completely fine, don't miss out those far lateral disc which lies outside the spine and bothers the exiting root. So this is what all information you want from an MRI of a disc prolapse. MRI also helps you in identifying conditions which mimic sciatica because of disc, like granulation tissue or pus because of TB causing nerve compressions. So that you need to see. Sometimes when you're really confused and you don't know how to identify, very simple is try to see the white fat which is there. If there is obliteration of the fat, means there's a problem over there. So again, there is a fat here, you can see white everywhere, and one side suddenly you're seeing black, which means there is obliteration of the fat. Something has caused pressure over there. Most likely it is the disc. So that is what you see here. Just give me a second. Great. So sometimes you notice these type of scans where you see a bright white spot in a black disc which is a little bit of bulging. This is a sign of an acute injury to the disc where the annulus has torn, and the white is the fluid area and the soft disc material which is around. So typically these MRIs are seen in patients with locked back with sudden increase in back pain and sudden appearance of leg pain in a chronic history of back pain patients. When you start seeing a disc, then you have to start correlating it radiologically. So here you need to know the concept of what nerve is going to get compressed. So inner spine, when you look from the back, this is where the nerve roots are going to go from, and at every level they come out. So let's say you have a disc prolapse at this area, and it is a central or a posterolateral disc prolapse. If it is a L3-4 level, then you will have a L4 nerve root compression. Okay. Whereas if it is a lateral disc, which means if the disc is compressing in the central, it is the roots going down which will cause problem. And if it's a lateral disc, it will be this root which is going to cause problem. This is important to again correlate clinically as to which nerve is getting compressed. It becomes more and more significant when you're doing minimally invasive procedures where you want to do targeted root treatment, like put steroid over there or endoscopically free that particular nerve root. So this is where you know what kind of disc prolapse will cause what kind of nerve root symptoms. So finally, when an MRI is placed in front of you, I would tell this. So the radiologist is going to give you a 2-page report about this, okay? Because it's his duty to read up everything about that condition. But we need to be very specific. And if I get an MRI like this, so if Miten sends me an MRI like this, what I'm going to tell him that this is a case of a L4-5 prolapsed right-sided. So L4-5 prolapsed right-sided posterior prolapsed intervertebral disc compressing the right-sided traversing L5 nerve root. So this is how you have to rightly describe a particular MRI of disc prolapse.
Priyank, we remember you touched upon how to number the vertebrae on the X-ray. Is
Yes.
there any tip or trick to not get confused when we are numbering or getting the level of the disc issue when reading an MRI spine on the sagittal? Can we pick up sacralization of the
Yes. So,
lumbar
so
vertebra?
basically what happens now is you can, if you're an expert radiologist or if you are, seeing spine MRIs every day, you can pick up signs which tell you that it's a sacralized spine. But typically sacralization is something that is described on a X-ray. But with the numbering, what problem happens is a radiologist always numbers the spine from the top to bottom. So C1 to C7, D1 to D12, and L1 to L5. Sometimes what happens is that the first sacral vertebrae has got a patent disc and is mobile. So when the radiologist counts from top to bottom, he will label as L1, 2, 3, 4, 5, and L. So say S1, which is there, is actually mobile. Okay, so on a MRI, it gives us an impression that that is L5, but technically that is not L5, that is S1. So if it is a
Right.
normal MRI, it is going to read L4-5 this prolapse. But let's say this was a part of the sacrum which is now lumbarized, then the radiologist will then label this as a L5 S1 disc, and then you will be confused because it's looking different. So,
Right.
so spine surgeons actually talk the if you really want to talk and where there's a confusion in the levels, two things you can do is if the radiologist has labeled something as L45, you use that as your terminology. So there is a universal dictum. And if there's no labeling, then you count as mobile segment. So here it is going to be last mobile segment and second last mobile segment. So
Right.
if the radiologist has not mentioned anything, I will talk instead of L45 disc prolapse as a second last mobile segment prolapse intervertebral disc. Okay.
Right. And that was an important point that you made there. So we now the radiologist basically numbers them from the top.
Yes, yes. And we
Right.
basically see our limited lumbar images, so we start counting from bottom. But
Right.
yeah, but that's just, it's tomato and tomato. That's all. It really does not make any major difference.
Right. Please
So
carry on.
from a clean prolapse intervertebral disc, you go back to something where lumbar canal stenosis is. So first thing that you know that it's a lumbar canal stenosis disc is outright you see a dirty looking MRI, which means that all the bones are looking funny, degenerated. All the discs are looking black. Multiple discs are getting bulged over here. So suddenly you know. And one more thing that you notice here, which is different, is that behind the cord there is nothing white, it's all black. You see this? So as contrast to this, see this MRI, which is of the disc, where everything is white, the bones are looking nice, there is white behind the cord, so fat is still intact. So what happens in stenosis is there is arthritis of the facet joint and there is disc bulge. So the poor cord is getting crushed from all sides, and that is basically what lumbar canal stenosis is all about. So in lumbar canal stenosis, you try to identify the facet joints, which look like this on a anatomy specimen, where there's one bone, other bone, and there's a synovial, means there's a smooth fluid-filled area, which looks like this on a T2 weighted image because it's white in color, which looks like this on a T1 weighted image. Okay. So this identify the facet joints. And what happens in lumbar canal stenosis is you see facet arthritis, which means there is the joint space has got effusion, which means the joints have become a little loose and filled with fluid. You will see that the soft tissue here will also start the soft tissue here will also start getting hypertrophied. The disc is going to get bulged. Okay, guys, I'm sorry. I'll have to just take a break for a second. My charging is going to go away. All right, just give me a second.
So next Sunday, we're going to be talking about an important management dilemma. This is me speaking. So I had my screen off. I'm Dr. Miten Sheth. We're going to discuss lumbar canal stenosis with varus osteoarthritis of the knee. So you have many patients in our Indian subcontinent that have bilateral varus osteoarthritis of the knee with LCS. And many a times we are wondering whether the claudication is significant enough to be treated first, or the knees are worse enough to undergo an arthroplasty first. And Priyank and I are going to discuss this. Priyank, are you back?
Yes, I'm back. And yeah, that's going to be a very interesting topic because even now we are stuck with those kind of dilemmas where, what to do first for this patient. So that we'll have next Sunday. Back to our today's talk is so in patients with lumbar canal stenosis, you are going to see loose joints, full facets. You will see ligamentum flavum hypertrophy. You will see the canal is constricted from mostly all the sides. So different types of facet arthropathy are like this, where in lysis you will see that the facets the this facet, which is ideally supposed to be back, has moved in front. The lateral recesses are obliterated. There's, all this uneven, dirty looking bony margins. You don't have to be very specific. You just look at it and it looks like a dirty looking MRI, which means there's some problem. There's a lot of unequal new growth that is happening, or you can see a lot of ligamentum flavum. So this is the ligamentum flavum area, which is completely compressing the central canal over here. Or this times where the joints have really become fat and they are now pressing the cord over here. So here what we really do is, in surgery we cut off all these things, we remove all these extra bone growth that is compressing the canal, and we open it up. So you see a normal looking round cord, dural sac area, which is totally compressed over here. So that is basically facet arthropathy, which is the most important component of lumbar canal stenosis. Sometimes the patient has got significant symptoms, but on the first look, the MRI looks pretty okay. There you need to focus a lot more and identify these things. So sometimes you see this white balloon like structure on one side, which is basically facet cyst. So that is basically extension of the synovial joint over here. Along with the synovial membrane, it comes out and it fills with fluid, and that is basically called as a facet cyst. And when we surgically remove it, it looks like this. It's like a ball which is formed in the spine, which starts compressing the spine. Now, the next part that comes in the discussion is how much compression is really significant. So, it does not matter what your MRI says. So, MRI is helpful to correlate the symptoms with the patient as. So, someone with a bad looking MRI might really be very comfortable, whereas someone with just a chotusa disc on one side, with the remaining everything, might be in terrible shape because he's got significant one level compression. So don't look at the MRI and take decision of the patient. We are not here to treat the scan. We are here to treat the patient. So see the patient, see what symptoms we have, and try to find out the cause of that symptom or sign by looking on an MRI. Okay. There are other conditions also which can be identified on an MRI. A few of them are lysis. So if you don't know, lysis is where the pars breaks, because of which the spine becomes loose and then starts moving. So lysis is not something that can very easily be available, seen on an MRI. But in lysis, what happens is that the pars area breaks. When it breaks, you might not be able to identify that on an MRI, but because of the break, when this becomes unstable and starts shifting, is the time when you will be able to make it out, because what you'll see is the spine is shifting, the alignment is distorted, and the defect in the pars is something that is then easily able to identify. The So one very important thing in lysis is, what happens is, this is the pars when you look from the back, which is broken over here. uh, Sometimes even in degenerative lysis where the pars is intact, you can still have a shift. The difference between a degenerative symptom and compression and a lytic symptom and compression is, in lytic lysis, the central canal is not a problem. It is only the lateral recess that gets compromised. So these patients can have terrible neuropathy, terrible radiculopathy, single root weakness, but they will never come with cauda equina syndrome. Whereas a degenerative lysis is something where that entire spine is shifting in front. You will see foraminal stenosis, and you'll also see significant central stenosis. So degenerative lysis patients are the patients who can get into cauda equina type of a symptom. So this is basically everything that you see in a degenerative lumbar spine MRI. The rules for the cervical spine are very similar. Again, you look for the alignment. You pick up the T2 weighted image, because again, the CSF is white over here. You see the alignment, you see the quality of the bones, you see the discs, you see the cord. And here you can very well see that the cord is getting compressed from the front and from the back. And then there is cord which is compressed over here, which is showing some whitish color in between this gray area. So this is basically what a cervical spondylotic myelopathy MRI looks like. Individual levels can be seen on axial cuts, where you can again see the central canal over here, and then you can see the white lateral recess. And it is obvious at this level how the central canal is causing cord compression and lateral recess compression, whereas here the cord and lateral recess is free. These type of patients need surgery, and post surgery the posterior elements are all removed and the cord is freed, and they can come back with a MRI of post surgical MRI where you can see that the cord is adequately freed. So in these patients, if there are residual symptoms, you want to know if the symptoms are because you have made the spine loose because of doing a surgery and removing a part of the spine. In that case, you do a dynamic X-ray to see if everything in this in the same line. So here you can see how a degenerated spine is causing compression of the cord, which is relieved after removing the posterior compressing structures and making the spine free from the front, the cord free. Sometimes you get these type of patients where you see there's some marginal compression, but patient is having a lot of symptoms. So I'm sure you guys know about the concept of static compression and dynamic compression. So now we have got dynamic MRIs where the spine is moved from position to position to see what is happening inside. And look what is happening in this patient. When he flexes in the front, the cord is completely free, but when he extends, there is a significant compression here. So this explains the symptoms of these patients, and these patients either do better with stability training or with a fusion surgery. So these are the newer type of MRIs that have started coming in. And of course, then there are those 10-15% red flag MRIs where you really don't have to put a lot of brains over there, because that is something that we can't treat. That requires a lot of evaluation, that requires a lot of investigations before we form a treatment plan. So you can't outright start treating this patient by doing exercises or so these are all red flag MRIs. So these red flag MRIs, you should be able to identify them, and the easiest way to identify them is if you see an MRI with the disc and the bones involved and there is a lump which is compressing on the cord, then it's either infection or a tumor or something. And this is typically how an infection MRI looks initially when it is started, and eventually when it is healed with fusion. So these are all red flag MRIs where you need to know the diagnosis, you need to know how to go about with the treatment, plan the treatment. And usually it involves multiple doctors like a spine surgeon, a physiotherapist, a chest physician, a physician, and all these things. Sometimes, again, this is not something commonly we see because trauma patients usually land up with the emergency rooms. But trauma MRIs are those MRIs where you'll see that the alignment of the spine is grossly broken at an area. There is malalignment. If you have X-rays or CT scan, you can see how the bone is broken and the cord gets terribly compressed at one area. So this is how a trauma MRI is going to look at. So if you get an infection trauma MRI, so basically a non-degen MRI, then those are red flag conditions where you have to be really careful. So this is basically covering the MRI in short, very specific, and only so that you can become better clinicians, because just reading the reports, you're going to be really confused. So a quick summary: whenever you get an MRI, pick up the T2 weighted sagittal section, then go to the T2 weighted axial sections, read up, see what is the problem, identify, see the alignment of the spine in general, see individual bones, individual disc, individual joints, and see the nerves, identify the levels where there are problems, go a bit in detail and try to correlate if the level that is having a problem on an MRI, will it show the same clinical picture that you expect? And if that's the same, you have come to the diagnosis and you're headed to with treatment. So I think this covers up most of the MRI bit of the spine. Uh,
Priyank, we have
yeah,
some questions on the chat box.
yes.
Uh, Number one, do you have any images of the ligamentum flavum on a sagittal MRI? And could you then show us ligamentum flavum hypertrophy? How to
Yes.
pick that up?
So we have it. So remember what I told you that see this. If you see this spine, this is a sagittal sequence, and I here want to first stop sharing the screen and reshare because I'm going to show a spine model. So is the model visible over here?
Yes, it is.
Yeah. So when you look from the back, that is the spinal, that is the lamina, that is the lamina. In between this is the ligamentum flavum. Okay. So when you see from the sagittal area, this in between stuff that you see here, that is the area of the ligamentum flavum. And when you see in the axial area, this is the area of the ligamentum flavum. So now I'm again going to share back my screen. So here, if you see, I'm going to zoom this. You see, this is the body. That's the spinous process here. That's the spinous process here. Do you see this black line? That is the ligamentum flavum. And do you see this whitish grayish area? That's the epidural fat. In the axial cut, this is the ligamentum flavum. And this is how a normal ligamentum flavum is going to be. Now, I will show you how a ligamentum flavum hypertrophy is going to look like. So, if you see this section here, do you see this? This is a normal ligamentum flavum with an epidural fat pad. But do you see this black bulge over here with no epidural fat pad? So this is basically the hypertrophied ligamentum flavum, which on axial cuts is going to look like this. Do you see this fat ligamentum flavum here? So that is basically what ligamentum flavum hypertrophy is all about.
Great. One more question. These may be too generic, but I mean, if you can touch upon these.
Yes.
Number one, what are the signs on an MRI or the clinical picture of a patient that will warrant you to advise for a dynamic X-ray or an MRI?
Yeah.
So, and the second one is, what are the indications for asking for a screen of the whole spine when you're looking at a patient with just lumbar complaints?
Perfect. So this actually is a very important and practical question. If you see an MRI like this, where the patient is full-blown myelopathic, and you are just surprised that there is not a lot of significant compression in the spine. See, this is a significant compression in the spine here. Okay. Even a small kid can say that the nerve is getting pinched over here. Okay. But if this MRI is given to a highly trained radiologist, he will not be able to completely comment with assurance that there is compression over here. So whenever you see an MRI, whenever you see a patient with profound clinical symptoms, but MRI not showing that bad, is when you start thinking that the patient has got some dynamic problem. So where you have the machine and the luxury, you get a dynamic MRI done, which can show increase in compression on extension or flexion. Where if you don't have that, then you do a flexion extension X-ray. And if the flexion extension X-ray shows additional movement at that level in question, then it correlates that there is a dynamic problem. A whole spine screening sequence has to be done in each and every MRI, because every you have to look and treat at the treat the entire spine as a whole, because a patient might have a very mild lumbar disc, but he might have a full blown cervical spondylotic myelopathy. Now you want to know all these things before you touch the patient, because a hidden cervical compression without myelopathy and you manipulate in the wrong way can lead into a central cord syndrome. So a whole spine screening should be done with all MRIs.
Perfect. Can you share something on DISH or OPLL?
So DISH and OPLL is basically different kinds of two different conditions. What happens in DISH? DISH is something called as diffuse idiopathic skeletal hyperosteosis, wherein what happens is all the new osteophytes which are getting generated, okay, that becomes amplified. So instead of having a chotu sa osteophyte developing, you have a big fat osteophyte that develops, and that is what is DISH. And DISH usually you see in the front where the traction osteophytes and degenerative osteophytes are getting developed. OPLL, on the other hand, is a condition which is called as ossified posterior longitudinal ligament. So the PLL over here in certain conditions get completely calcified, and that kind of compression probably looks something similar to this. You see this black line becoming completely fat here. So that is, you'll see a thick black line in the back, and that is basically what OPLL is. I have a few images of OPLL if someone really wants to see it.
Meanwhile, there's
Yeah, you
one
can ask
last.
me the second question. Till that time, I'll just show a image
Sure.
of an OPLL. I've already pulled it up online. Let me just share my screen so that they know what is happening. Just give me a second. Huh?
Right. There are two other things that we are requesting. One, if you
Yeah.
can
So,
explain
Miten, just one
one line.
second. So, this is basically what an
Okay,
OPLL
great.
is. You see this black, thick
Perfect.
line in the
Right.
back? That is what OPLL is. Okay.
Super,
So,
super.
that's for the OPLL.
Can you please
I
explain again the lateral recess block and the concept of exiting and traversing nerve roots again?
Okay. So again, I'm going to take my model and I'm going to show it to you like this. This is how your nerves go. Okay. So that is where your nerves are going. Okay. And this nerve starts exiting at every level. So you have one root coming out of here, one root coming out of here. Okay. So the root comes out through a hole, which is basically the foramen. And if you look from the top, okay, do you see my pen in the center? And do you see the pen outside? In between that, there is this area of bone. This entire corridor is what is called as the lateral recess. So whenever you have a disc that comes out, so when the disc comes out, it comes over here. It comes out in the center, it comes out in the lateral side, it comes out and in the foramen or extra foraminal side. So when the disc comes out in the center, it is the disc is over here. So when the disc is over here and it comes out in the center, it is going to compress the root which is going down here. Because if you see here, see the disc is here. When the disc comes out at this level, the root has already exited up. So the central disc is going to compress the traversing root, whereas a lateral or a far lateral disc will compress the exiting root. Practically, this is important because if let's say if we have a L45 central disc prolapse and you want to give a root block, you will give root block to the L5 root because that's the traversing root. But if you have a L45 far lateral or a foraminal disc prolapse, then you know it is the L4 nerve root that is going to get bothered, and you give medicine around the L4 root.
Super. Right. There's one more question. Whether it's dish or lumbar spondylosis, sorry.
Uh-huh.
Is there any difference to the disc space? Like, does the disc space, is the disc space reduction seen?
So if you actually start going detailed, see, one is there that dish, okay, or lumbar spondylosis. So what lumbar spondylosis is all about is that the disc becomes degenerated. There is abnormal micro movement that happens, and to stabilize this micro movements, body starts throwing osteophytes over here. And basically, what that does is that grows extra additional osteophytes here. In a condition like disc, that osteophytes are like elephant trunks, they cross across the entire body. So basically the
So there will be
spondylosis.
osteophytes, but will the disc space be reduced
Yeah,
in a
so what
disc?
happens is this. Now the osteophytes basically are to stabilize the area. That's the reason why the osteophytes are getting developed. So if you think about it, when you have a lumbar spondylosis, you will see a lot of degenerated disc. Okay, because by the time the chota osteophytes actually bridge and make this stable, the disc is significantly degenerated. Whereas in dish, what happens is that the osteophytes develop ekdam fatafat. That's why before the disc completely degenerates, that area has become stable. So if you actually look at the quality of the quality of the disc is going to be better in dish rather than in just a plain lumbar spondylosis.
Okay.
But it
Last
really does
question.
not have a practical relevance.
Right, right, right. The last question we are going to take, we are at 55 minutes, and I think this has been wonderful utilization of time. If we have a patient with lumbar scoliosis on physical examination, what are the next tips as regard to investigation? Do we advise a complete spine X-ray, or what screening needs to be done for a patient with scoliosis?
So scoliosis again will be of two types. One is a adolescent idiopathic scoliosis or scoliosis which is seen right from childbirth and in children, and then you have degenerative scoliosis seen in old people. In degenerative scoliosis patients, you require to do a you require to do a MRI scan just to see, because it's again going to present as a lumbar canal stenosis or a PID patient. So MRI becomes mandatory over there to treat. Whereas a scoliosis kid, does not require an MRI. So for a scoliosis kid, what you need to do is one definitive spine surgeon evaluation, because the first thing in a scoliosis kid is to evaluate if the scoliosis is going to progress or not, if it is going to require surgery, bracing, or only exercises. Once that is identified, and that is going to be identified with the help of doing x-rays, bending x-rays, clinical exam, then there is risers grading, then you have to measure the curve. It's very complex. So a first scoliosis evaluation is at least a 1.5 hour consult, where you have to do all these detailed bits. So you can't generalize scoliosis by just saying, okay, do an MRI and come, or do an X-ray and come. In
Right.
fact,
But the small key was no MRI for an adolescent.
no MRI. In fact, a scoliosis patient, no X-ray also, because a scoliosis is seen especially in young girls than boys. And whenever they have all these things, the spine surgeon himself is going to ask for a lot of X-rays. So there's going to be a lot of radiation in that kid for a long time. So basically, a scoliosis evaluation should be clinical, and then the specialist should then decide what all investigations are done. But adult scoliosis, definitely an MRI.
This was really an informative session for me as well, because we don't see as many MRI finds as many of those attending this webinar. I'm speaking as a knee surgeon here. Number one, we would like to thank everybody, the 32 participants, 36 at one point on this Zoom meeting today, plus the others on YouTube. From Advanced Orthopedics as a quartet, Dr. Chintan Desai, Abhishek Kini, Priyank here, and me, Miten. We are doing this because we feel that empowering clinicians is very important to further patient treatment in our times, and hopefully we are making a difference. Thank you everyone for your time. Thanks Priyank for making it really simple and lucid, and we learned a lot of new things today. We'll come back next Sunday, and we are going to be discussing lumbar canal stenosis with knee osteoarthritis and varus deformity. So it's sort of a knee hip spine syndrome, how it develops as an etiology, what is the philosophy when we see these patients, and how we're going to approach this from a clinical perspective. So that's about it. It's 5:59, which is, we planned this for an hour and hopefully utilize the time smartly. Thank you everyone for being there. Thanks Priyank for really a wonderful 1 hour session. Thank you so much.
Thank you, Miten. See you guys next week.
Right. Just to keep in tune with the updates, we would request you to go on to advancedorthopedics.in. That's our website. And if you can request to become members, we add you to this WhatsApp group. And we're planning to keep all of these updates and these webinars just to the WhatsApp group of members that we have. And it's going to be on every weekend, Sundays, 5 to 6. It's going to be an annual or a year or a 2-yearly process, where we can also include your suggestions as well. If you have any questions regarding this talk, you can write into us. You can, Priyank, could you give us a number where somebody can ask you questions regarding this talk here?
Yeah, so I'm going to put it up in the group chat, my email and my WhatsApp number.
Super. Right. Thank you, everyone, and wish you a happy Sunday, whatever's remaining of this.
Thank you, guys. See you next week.